This patient is a 35-year-old male with a history of palpitations and documented narrow complex tachycardia. The baseline electrocardiogram demonstrates Wolff-Parkinson-White syndrome. Informed consent is obtained from the patient while discussing the plan for the procedure as well as the risks involved. The patient is brought into the electrophysiology laboratory and defibrillation patches, grounding pads, ECG leads, blood pressure cuff, oxygen saturation monitor, and three-dimensional mapping system patches, if used, are applied. Mild conscious sedation may be appropriate. However, if the patient can tolerate using only local anesthesia with little or no conscious sedation, there is a better chance of inducing the clinical tachycardia. The patient is then prepped and draped in the standard fashion. Here we are entering only from the femoral veins, though some operators may choose to access the internal jugular or subclavian veins as well. After prepping the areas for venous access, sterile draping is applied. The operator and others involved directly in the procedure perform a sterile scrub and don sterile gown and gloves. The cables are plugged into the appropriate locations in the pin block to allow monitoring and recording during the procedure. The equipment needed for the procedure should be immediately available, including a local anesthetic such as lidocaine with needles and syringes, introducer sheaths of varying sizes, catheters, and associated cables. In addition, a recording system, pacing stimulator, and fluoroscopy are needed. Intracardiac echocardiography and three-dimensional mapping system are optional, but may be helpful. In order to obtain venous access, first feel for the femoral artery, which then identifies the location of the femoral vein about 1 centimeter medial to the artery. Local anesthetic over the femoral vein is given at this point. Local anesthetic also is given in a similar manner over the contralateral femoral vein. After adequate local anesthesia has been achieved, the femoral vein is accessed using the modified Seldinger technique. Up to 3 introducer sheaths may be inserted into each femoral vein, about 3 to 5 millimeters apart. Ultrasound guidance may be desired for venous access because it allows entering only the anterior wall of the vessel, reducing the likelihood of post-procedural hematoma. After the wire is placed in the vein, the sheaths are inserted over the wires and secured in position. Venous access and sheath insertion are then performed on the contralateral side. Once venous access is obtained, the electrophysiology catheters are inserted. Catheter placement can be monitored using fluoroscopy or with a three-dimensional mapping system. The electrophysiology monitoring catheters are placed in the high right atrial, His bundle, coronary sinus, and right ventricular apical positions. The coronary sinus catheter should be placed with the most proximal bipoles at the coronary sinus ostium. The next step is arrhythmia induction. This protocol typically includes ventricular burst pacing, with care taken to examine for a concentric or eccentric retrograde activation sequence. In this example, the patient has eccentric retrograde atrial activation. Note that the earliest atrial signal is on the distal coronary sinus, or CS1-2 electrogram. If there were concentric activation, the earliest signal would be the His catheter, or coronary sinus ostial electrograms, CS9 and 10. He then goes into atrial fibrillation. Note that the shortest pre-excited RR interval is 228 milliseconds, which is a marker of a high-risk bypass pathway. The patient then spontaneously converted back to normal sinus rhythm. Ventricular single extra stimuli are also completed, looking for changes in the retrograde activation. In this example of loosely coupled ventricular extrastimuli seen on the left, there is fusion of the retrograde atrial activation pattern initially, with electrical signal conducting up the bypass pathway and AV node. With tighter extrastimuli seen on the right, however, the activation pattern changes to solely eccentric activation, as evidenced by a change in the timing of the signal on the coronary sinus ostial electrogram at CS9-10. The next step is parahisian pacing. In this example, there is both an accessory pathway and AV nodal conduction. Apical versus basal pacing may also be completed to look for concealed bypass pathways. Then atrial burst pacing is performed to look for maximal pre-excitation. Single atrial extrastimuli can then be completed, looking for refractoriness of the bypass pathway and initiation of the arrhythmia. With a tighter atrial extrastimulus, the QRS becomes narrow as the refractoriness of the bypass pathway is reached and the tachycardia is initiated. Cycle length and septal ventricular atrial, or VA time, should be measured. Once the supraventricular tachycardia has been induced, pacing maneuvers are completed to assess the tachycardia mechanism. The first maneuver should be ventricular overdrive pacing. Ventricular overdrive pacing should show evidence of entrainment, such that the atrial rate equals the ventricular paced rate and not the tachycardia rate. Then the atrial and ventricular response is examined, and the post-pacing interval and tachycardia cycle length measured. Other maneuvers to consider include His synchronous premature ventricular contractions, assessment of the pre-excitation index, and atrial or His overdrive pacing. Sometimes the arrhythmia cannot be induced during baseline conditions, and isoproterenol infusion is used. Once the mechanism of the tachycardia has been elucidated, ablation can be performed. In this example, a left-sided bypass pathway is present with orthodromic atrioventricular reciprocating tachycardia as the cause of the SVT. For a transeptal approach to bypass pathway mapping and ablation, a transeptal puncture is needed to access the left atrium. First, one of the smaller sheaths is upsized to a larger sheath to accept a phased array intracardiac echocardiography, or ICE catheter. Next, the ICE catheter is advanced into the right atrium. The ICE catheter should be maneuvered into the right ventricle to assess for pericardial fluid. The ICE catheter then is withdrawn into the right atrium to obtain a view of the interatrial septum. Once the anatomy has been visualized for the transeptal puncture, a 135 centimeter J-tipped guide wire is then advanced through one of the femoral venous sheaths into the superior vena cava to about the level of the carina. The introducer sheath is removed, and a long sheath and dilator are advanced over the wire up to the superior vena cava. The specific sheath used is the one that allows the catheter to best reach the presumed site of the bypass pathway. The guide wire is removed and the dilator is flushed with heparinized saline. The transeptal needle also is flushed with heparinized saline, and then the needle is advanced into the dilator and sheath assembly, with the needle oriented at about 4 o'clock. The tip of the needle is kept about 1 centimeter back from the end of the dilator. The needle should be attached to a transducer to measure the intraatrial pressures. The sheath assembly is then pulled down in the fossa ovalis. The needle is advanced until it enters the left atrium. Usually there is a pop sensation as the needle punctures the atrial septum. Once across the septum, a left atrial pressure tracing is seen. Alternatively, the needle may be flushed with saline so that microbubbles are visualized on the echo images in the left atrium. The sheath and dilator are then advanced into the left atrium with the needle in a fixed position. The sheath is then advanced over the dilator. The needle and dilator are carefully removed, and the sheath is aspirated and flushed with heparinized saline. A continuous heparinized saline infusion is then given through the sheath. The ice catheter is again advanced into the right ventricle to reassess for presence of pericardial fluid. A heparin bolus is given and continuous infusions started to maintain therapeutic anticoagulation during the ablation procedure. The ablation catheter is then advanced through the sheath into the left atrium. The catheter position is monitored using fluoroscopy or the 3D mapping system. An alternative method to reach the bypass pathway is via a retrograde aortic approach. The transeptal approach allows for greater catheter mobility and easier manipulation, but catheter stability is better with a retrograde aortic approach. After the catheter has been placed in the left atrium, mapping of the bypass pathway is completed. This can be done with either antegrade or retrograde mapping. If antegrade mapping is completed, pacing from the bipole nearest to the bypass pathway will maximize pre-excitation and ensure accurate mapping of the pathway location. The ablation catheter is maneuvered along the mitral annulus, and characteristics of a good ablation location are sought. These include the earliest ventricular electrogram prior to the delta wave, shortest AV interval, QS morphology on the unipolar electrogram, good electrogram stability, and presence of an accessory pathway potential. The atrial to ventricular electrogram ratio should be about 1:1, as seen in this example. The short, thick arrow points to the atrial signal, and the long, thin arrow points to the ventricular signal. The other option is to map the bypass pathway with ventricular pacing and retrograde conduction. Ideally, ventricular pacing near the bypass pathway should be completed to minimize fusion with retrograde AV nodal conduction. A short VA time with the earliest atrial signal, often with continuous electrical signal between the ventricular and atrial electrograms, suggests a good ablation location. In addition, there should be good electrogram stability, and the presence of a possible accessory pathway potential should be sought. For the ablation, the radio frequency generator is programmed to the desired settings. In this case, 50 watts and 50 degrees for 60 seconds was used. The ablation is then started, with the goal being loss of the delta wave or loss of retrograde activation. In this case, there is loss of retrograde activation within 2 seconds of starting the ablation. Oftentimes, additional ablation lesions are placed near the first lesion to reduce the risk of the pathway reappearing. After a successful ablation, there is a waiting period between 20 and 60 minutes to assess if the bypass pathway has recurred. Attempts are made for reinduction of the clinical or another arrhythmia, frequently with reintroduction of isoproterenol. Once the waiting period has been completed, the catheter is pulled back into the sheath and the sheath is withdrawn back into the right atrium. The catheter can be removed from the body. The heparin infusion is stopped. The long sheath is then exchanged over the long J-tipped guide wire for a shorter introducer sheath. All catheters are removed. The sheaths may be left in place until the ACT has dropped below 150 to 250, or protamine may be given to reverse the heparin anticoagulation. The sheaths are then removed with manual hemostasis obtained. All cables and drapes are removed from the patient. The patient is then transferred to a stretcher. It is important not to bend the legs for 4 to 6 hours after the procedure to prevent the development of hematoma.